Hi, I'm Dr. Carl Hasselman. I'm from West Virginia University. I'm here to talk to you about the Lapidus I-Beam plate. This is a new and innovative idea from Arthrex. This kit will be designed for Lapidus corrections of hallux valgus. The plates have two different designs. The first is the actual I-Beam plate, which will have an I-Beam portion to it. The second is the flat plates. These will come in left and they'll come in right based on which side of the foot you're working on. The third thing is they'll come in small, medium, and large. So in the kit itself, you'll have the plate option, small, medium, and large. You'll have the cutting block, which is here in white, and then you'll actually have the burr, which is just a 2 millimeter burr that we use to cut. In a separate kit, you'll actually have a sizing plate. This is your template and sizing plate. This will allow you to decide which plate you're going to use, small, medium, and large. This is a large I-beam plate. You'll see there's an L on the plate. That's the proximal side. You'll notice that the proximal side has a almost 45-degree angle between the two screw holes. That's designed to allow it to go under the tibialis anterior without damaging the tibialis anterior. What makes the plate unique and revolutionary is the concept of an I-beam. So you'll notice there's actually a second plate built into this. It looks just like an I-beam. The idea behind this is a second plate with the rigidity. You'll notice that there's a groove contoured into it, which allows you to visualize your fusion as it occurs to ensure you get the fusion. So if you look at the fluoroscopic image, this is a preoperative simulated weight-bearing image on a cadaver. You'll notice that there's an increased intermetatarsal angle. You can see the subluxation of the sesamoids. Unfortunately, this is an arthritic hallux valgus, but regardless, it does have a hallux valgus. You'll notice that the proximal phalanx has gone into the abducted position, which is pretty typical for the bunion deformity. So now we have our pins in. Once again, you'll notice I'm going to start correcting. And as I correct, notice the toe not only goes from abduction, but goes back into straight neutral. But you'll also notice this paddle as I'm reducing goes from down, and it's literally rotating upward. So it's actually doing triplanar correction. Once I have that reduced and I'm quite happy, then I'm going to come down here and put on my lock. And then as we lock this down, it's going to hold me reduced. And so now I'm quite happy with it. Clinically, it looks nice. It looks straight. It's triplanar corrected. What I'd really do at this point is get an x-ray to make sure I'm quite happy with how my reduction is. So you can see now we have a fluoroscopic image after the clamp's been applied. You can see that the clamp not only has anatomically reduced the first metatarsal, the intermetatarsal angle is back to normal. The sesamoids are completely back under the first metatarsal where they belong. This is an anatomic reduction. The nice thing is the clamp is holding it into place. And so it becomes a hands-free technique. You don't even need an assistant with this. One of the things I'll do if I do not use the bunion clamp to anatomically reduce the hallux, the other thing I'll do is I can take a knotless 1-1 mini tightrope or even a 2-7 knotless mini tightrope. And what I can do is I'll place it more proximally along the first and second metatarsals, and I'll use that to anatomically reduce the intermetatarsal angle. That also works very nice as a clamp because it will anatomically reduce it and hold it as well. So you actually have two options from Arthrex to reduce and hold your intermetatarsal angle alignment and control rotation, making it a much more hands-free technique. We've done our distal soft tissue release. We've put our clamp on. We've done our reduction. Now what we're going to do is go ahead and stabilize that first tarsometatarsal joint. And so I like to go from dorsal to plantar. I just kind of like to make it a straight midline incision. And the reason I do that is I think it's very cosmetic because when they look down, they won't see the incision on the medial side of the foot, as opposed to a lot of times for cosmesis, they don't like incisions on the top. So this is a much more cosmetic incision. Typically, I will make the incision based off of that joint. I will make a smaller incision. That's about the size of the incision I would typically make. For this teaching video, I'm obviously going to expand it a little bit just for better visualization. So I'll make it longer, but typically as you do this, you'll find you can make it much smaller. And I think I'm just going to do that more for visualization. The next thing I'm going to do is kind of get an idea of what size plate I'm going to use. You can kind of first put it down and look if you want to get an x-ray, but most of the time what I would say is I'm going to take a knife and I'm going to expose it. Once I have this done, now I'm ready. And this is where I typically like to put my template on. It'll give me an idea of what I'm going to do, what size plate I'm going to use, what I want to do. Remember, I want to cross the joint This is a left foot, so this is a left template. It'll say left, and you can see it, and you'll see there are different grooves on here. There's small, medium, and large. And the idea behind this is that we'll be able to put this down onto the shaft of the first metatarsal and the joint. And now I'm sliding it so that it's going to follow that path about where I want it. You'll see how it's sitting nicely. You see the tibialis anterior is coming at a 45-degree angle. This thing has a 45-degree angle, so I'm going to be able to slide it right down under that tibialis anterior nicely. And you can see with my window, I can see my joint. So this is actually a lateral view of the foot under fluoroscopic image. We have the template now put right where I want it, so I've kind of visualized where I want it, and now I'm looking at it here. So you can see there's a circle proximal. That's actually going to be your proximal locking screw. The template's designed, it has 3 open oblong holes. The first one's much longer. That's actually going to be where the I-beam portion would sit for a small plate. The second oblong would combine with that first one. That's where the I-beam will be for the medium plate. And then obviously the third one is the large plate. And so the idea is you want to make sure that your I-beam's obviously going to cross the joint. You set it proximally where you want it, and then you measure which one you want, small, medium, or large. In this one, I think a medium would be perfect. The next thing we're going to do is prepare the joint. And so basically, we're going to take our 2mm burr. This 2mm burr will not only be used to prep the joint, but it'll also be used to make the slot for the I-beam plate. And you want to use lots of irrigation. I don't think on this one we use much irrigation because it's the cadaver, but you can hear that I'm literally burring. And then you'll notice all I'm doing is literally taking off the cartilage. You'll notice that I'm staying within the joint. The nice thing is you can see it. You can actually visualize, and you can see that the cartilage is nicely ripped off of both sides. And so you'll see I nicely and very quickly remove the articular cartilage. Typically, once I've done that, then all I'm going to do is I'll take a very small osteoma. The osteoma I would use would only be maybe 1/8 of an inch wide and shorter, but just so you can see the technique. Once I do this, then I'm going to go ahead and hold it there. But all I'm really doing is just going to pie crust it a little bit, and I'm not going to belabor this point. But the idea is once I've pie crusted my joint and I'm ready, if I see any articular remnants left, then I'm just going to once again put my burr in, and I'm just going to morselize those little pieces. And I would make a small 1 centimeter incision on the lateral side of the heel here, take the osteoauger, and I would collect some calcaneal bone graft because I want to fill this in. And usually what I'll do is I'll get a small amount of calcaneal bone graft. I'll mix it. Typically, I like to use Arthrex to give me some live, healthy bone, and then I'll pack it in. So what I'm going to do is I'm going to take that bone, and I'm going to start packing it in. Once we have that done, then we're going to take this, but this is mostly for visualization. This is going to be my cutting block or my cutting guide, and you'll see that there's a line right down the middle of this guide, and that actually wants to be right over the joint. So I'm going to put this on just where I would put my medium plate, and this is going to be for a medium. I'm going to make sure I'm on the medial side. Remember, you don't want to be dorsal medial, you don't want to be plantar medial, you want to be medial. And it can be a little bit, but then you're defeating the purpose of the I-beam. That line is right in line with my joint that I've prepared. And so with it there, I'm now going to hold this into place. I'm holding it right where I want it. And I'm just going to use a couple of headless BB tacks. Again, the nice thing is my tibialis anterior is out of the way, so I don't have to worry about injuring it because of the shape of the plate. So once I've done that, the block is designed to work perfectly with this burr in the sense that what'll happen is as this burr goes in, it's going to go right to the depth. You'll see the burr sticking up off the plate a little bit. The idea is that as you now run this along, this is going to be so we can seat the I-beam. We're going to take it, and you'll notice that the first thing I'm going to do is let it fall down. And now the neat thing is it stops, and you can see the burr can't go any further because the stop, and it's designed for that perfect depth. So now I can literally just slowly let the burr work its way across. You can make sure that you can, if you want irrigation, you'll see the irrigation's going right inside the middle of it. But I'm literally just going to run this straight down. Now you can see it jump because I crossed the joint. And if you want to, you can also, if you prefer to punch and slide, you can do that. If you want to, you can just slide it. But the whole idea is, what I've done now is I've cleared that whole area. We've now prepared it. So the joint's prepared. We have a slot created in the bone, both on the first metatarsal and on the medial cuneiform. The nice thing is now we can take our medium plate. I can lay it right down on that slotted area. Our plate is in place. You can see we're down on bone. We're in a good alignment. Give you an idea, that's where we had our BB tack, that hole there. So that tells me we're kind of right down where we want to be. At this point, what I'm going to do is I'm going to put 4 locking screws in to hold it. I like to use the Cruel Lock locking screws because they give me a little bit of variable angle, but they will pull the plate down to the bone and they give incredible fixation. And so this is the final construct for the I-beam. You'll see that the I-beam itself is intact. You'll see that we did 4 locking screws. You'll notice that the tibialis anterior, if I let go now, the tibialis anterior will fall nicely back into place over top of the plate. It's not being irritated by the plate. It's just sitting where it belongs. You could, if you really wanted to do an intermetatarsal kind of fixation, you could use one of these as a cancellous because your primary fixation is actually going to be that I-beam plate construct underneath. That's just an option if someone wanted to reduce or hold the intermetatarsal angle. So now if you look at the fluoro images preoperatively and postoperatively, you can see we've now taken our clamps off. You still have maintained anatomic reduction and alignment of the intermetatarsal angle. The sesamoids are perfectly rotated and put back under where they belong. If you look at the final picture of the foot, you can see that you have a completely cosmetic foot. The only incision you're going to have is a very small incision between the first and second, which will actually heal up very nicely as long as you stay in the web space. All the rest of the incisions are done medially, and so this is actually very cosmetic. The most important thing also is you'll notice we did not shorten the first toe. This technique does not shorten. It merely reduces that first tarsometatarsal joint, and so patients don't have a shortened first toe, and you can see we have anatomic alignment of the toe.